Prior to performing the procedure, introduce yourself and verify the client's identity using agency protocol. Explain to the client what you are going to do, why it is necessary, and how he or she can participate. For touching the patients, of course, don't forget to perform hand hygiene. Provide for client's privacy. In women, drape the anterior thorax when it's not being examined. And don't forget to inquire if the client has a history of the following family history of illness, including cancer, allergies, tuberculosis, lifestyle habits such as smoking, occupational hazard, medication being taken, current problem like swelling, cough, wheezing pain. Assess for configuration. While the client sits with arms at the side, stand behind the client and observe the positions of the scapula and shape and configurations of the client chest wall. Inspect the shape and symmetry of the thorax from posterior and lateral views. Compare the anterior-posterior diameter to the transverse diameter. Inspect the spinal alignment. For deformities if the client can stand, from a lateral position, observe three normal curvatures: cervical, thoracic, and lumbar. To assess for lateral division of the spine, observe the standing client from rear. Have the client bend forward of the waist and observe from behind. Observe for retractions of intercostal spaces, use of accessory muscles, rate and rhythm of breathing. Warm hands before touching the patients. You can use one hand or both hands. Okay. Palpate using the palpation sequence. Palpate for lungs, muscles, pulsation, tenderness, sensations, or crepitus. Your thorax for respiratory excursions. Place your hands on the posterior chest wall with your thumbs at the level of T9 or T10 and pressing together a small skin fold. Ask the client to take a deep breath while you observe the movement of your hands and any lagging movements. It's following the sequence described previously. So as you move your hands to each area, ask the client to say 99. Assess all areas for symmetry and intensity of vibration. For percussing the posterior thorax. Percuss per tone. Start at the apices of the scapula and percuss across the tops of both shoulders. Then percuss the intercostal spaces across and down comparing side. Percuss to the lateral aspect at the bases of the lungs comparing side. As for diaphragmatic excursions, ask the client to exhale first fully and hold the breath beginning at the scapular line T7. Percuss the intercostal spaces of the right posterior chest wall. Percuss downward until the tone changes from the resonance to dullness. Mark this level and allow the client to breathe. Next, ask the client to inhale deeply and hold it. Percuss the intercostal spaces from the mark downward until resonance changes to dullness. Mark the level and allow the client to breathe. Then measures normal 3 to 5 cm. It is 4 cm. Auscultate for breath sounds. To best assess lung sounds, you will need to hear the sounds as directly as possible. Do not attempt to listen through clothing or a trip, which may produce additional sound or muffled lung sounds that exist. To begin, place the diaphragm of the stethoscope firmly and directly on the posterior chest wall at the apex of the lungs at C7. Ask the client to breathe deeply through the mouth for each area of auscultation in the auscultation sequence so that you can best hear inspiratory and expiratory sounds. Be alert to the client's comfort and offer times for rest and normal breathing if fatigue is becoming a problem. Auscultate from the apices of the lungs, C7 to the bases of the lungs at the T10 and lateral from the axilla down to the 7 for 8 breaths. Listen on each side for at least one complete respiratory cycle. Okay, ma'am. Thank you so much.